One of our dental colleagues reached out for help. Clinical summary from history and images. The chief complaints being viscous sticky saliva, multiple carious teeth, recent extraction of mobile lower anteriors, parents' main concern, excessively thick saliva. The OPG findings being generalized poor dentition, multiple carious lesions involving both anterior and posterior teeth, likely periapical pathology in lower anteriors and some posteriors, malaligned and hypoplastic teeth in certain areas, bone level appears compromised in some anterior regions. Intraoral findings, grossly carious upper and lower anteriors with retained root stumps, generalized enamel hypoplasia or post-eruptive breakdown, sticky saliva visible intraorally, plaque accumulation and possibly poor oral hygiene. Soft tissue looks erythematous in some regions. The primary diagnosis being rampant caries with salivary gland dysfunction, possible xerostomia or altered composition, underlying associated conditions to rule out salivary gland disorders or Sjogren syndromes. Dietary habits, high sugar carbohydrate frequency or carbonated beverages. Medication-induced xerostomia, antihistamines, ADHD medicines, systemic metabolic endocrine disorders, uncontrolled diabetes mellitus. Congenital enamel defects like amelogenesis imperfecta or syndromic conditions. Oral fungal infections, neurological disorders affecting the salivary control, recommended investigations being first salivary analysis to check the flow rate both stimulated and unstimulated, pH and buffering capacity, microbial load for lactobacilli and streptococcus mutans, the blood test which involved the FBS, HbA1c, autoimmune markers of ANA, anti-SSA, SSB if xerostomia suspected. Nutritional review, 3-day diet chart, water intake frequency, sugar exposure frequency, IOPA and CBCT if surgical or restorative planning is extensive. Treatment plan, phase-wise. Phase 1, immediate management, motivational interview with guardian, explain the long-term implications and multidisciplinary approach, oral prophylaxis plus high fluoride varnish application. Prescription will involve salivary substitutes, high fluoride toothpaste, antifungal rinse if fungal infection is suspected. Dietary counseling, chlorhexidine rinse 0.12%, 2 weeks only if high plaque or inflammation. Phase 2 is stabilization, pulpal status assessment, restore all salvageable teeth with GIC or resin modified glass ionomer cement with temporaries, SDF application on grossly infected teeth and extract the non-restorable teeth. Phase 3, definitive restorative plan, young age consideration, composite strip crowns or stainless steel crowns if pediatric, if adolescent or older, post-endodontic restorations with core or crowns if needed, acrylic partial dentures or flippers until the skeletal maturity occurs. Consider fluoride trays or customized remineralization protocol.